First, I would like to extend my thanks to the organizers for inviting me here to share our clinical and research experiences on enhanced external counterpulsation in coronary artery disease and heart failure patients with you. But before I start, please allow me to ask this. Can you hear me from the back clear enough? Okay. So please allow me to ask this question to you, and please raise your hands if you have ever treated personally, ever treated a patient with EECP, or if you have ever referred a patient to EECP. Like just, all right, that's what I thought. All right. My talk will have 3 parts. In the first part, I'll try to focus on very briefly concept of counterpulsation, and then we'll summarize the results of clinical trials, and then try to touch the mechanism of action of EECP. This is the system that we are using at the University of Pittsburgh, which is called the EECP treatment system. It has a patient bed, which is attached to an air compressor unit that is attached to a control console. It is triggered with ECG, and we can monitor the systolic and diastolic waveforms throughout the treatment via non-invasive finger plethysmogram. 3 sets of cuffs wrap around the lower limbs and the buttocks of the patient. At the time of diastole, the sequential inflation of the cuffs increases retrograde aortic blood flow, therefore increases venous return, improve diastolic filling, and increase cardiac output. At the time of systole, though, the simultaneous deflation of the cuffs results in systolic unloading. And in fact, all these acute hemodynamic effects of EECP has been shown in the cath lab settings invasively by UCSF investigators, and they published their results in Circulation. This is a treatment for 1 hour per day for 35 days. If you want to summarize the benefits associated with EECP, including placebo-controlled clinical trial, I think this would be the slide. Significant reduction in angina, improvement in quality of life, prolongation of the time to exercise-induced ST segment depression, improvement in exercise capacity and duration, improvement in myocardial perfusion, and reduction in nitrate use. System approved, cleared by FDA back in 1995 for the use of stable angina, unstable angina, acute MI, and cardiogenic shock. And 4 years later, Medicare started to reimburse the treatment for refractory angina patients. But back then, the company thought that it would be contraindicated in heart failure patients, but at the University of Pittsburgh, we didn't agree with the company, so we suggested that it should be safely used in heart failure patients as well. Therefore, we started our first pilot study looking at the safety of the issue, and the results were very encouraging, which made us to take another step to do the feasibility study. This feasibility study was a multi-center study, which basically enrolled class 2, class 3 heart failure patients. I have to underline here that we did not enroll any class 4 decompensated heart failure patients. But we have enrolled both idiopathic and ischemic cardiomyopathy patients, and the mean ejection fraction for idiopathic group was 18%, and the mean ejection fraction for ischemic cardiomyopathy group was 24%. We have looked at the mean exercise duration. There was a significant increase in mean exercise duration, which maintained at 6-month follow-up. Then we look at the mean peak oxygen uptake. Results showed a significant increase after EECP treatment, but interestingly, it kept improving at 6-month follow-up. This wasn't a result that we were expecting, but I have to again underline here that this was a multi-center study with 3 centers who obeyed all the protocol rules. So it was a very nicely done study. We also look at the quality of life, showed a significant improvement, and our ECHO group at the University of Pittsburgh assessed the LV function. They not only measured the regular ejection fraction measurement, but they also calculated preload adjusted maximal power as a relatively load independent measure of LV function. So they showed a significant increase on ejection fraction and also significant increase in left ventricular maximal power. All these outcomes encouraged us to take another step to do a multi-center, randomized, single-blind, controlled clinical trial, which is known as PEACH trial. PEACH results were presented at the late-breaking clinical trials of ACC and also got published in JACC. And the main of the PEACH trial was to do whatever we had done in the feasibility study in a controlled fashion. The results basically in regards to exercise duration and functional capacity was very similar with the feasibility study, and the results and the conclusion of the PEACH study was that EECP provides adjunctive treatment in patients with class 2, class 3 heart failure receiving optimal pharmacologic therapy. In this particular study, we look at the clinical outcomes, event-free survival rates, and incidence of repeat EECP in coronary artery disease patients with left ventricular dysfunction. This was a 2-year cohort study, and I have to mention that the baseline characteristics of these patients were really poor. 45% had diabetes, 70% had MI, more than 90% had prior PCI and CABG, dealing with a group of poor functional patients actually. And all of them had an ejection fraction less than 35. And also they had severe angina. At the end of the treatment, 77% had angina reduction by at least one class. 52% stopped using nitroglycerin. We also look at the major events occurring during EECP, such as death, MI, bypass, and PCI, and that was less than 1%. 81% had no congestive heart failure exacerbation during the 2-year follow-up in this cohort. Also, we look at the event-free survival rates at 2 years, which was 70% in our cohort, and the pure survival rate was 83% in this patient population. In this particular study, we look at the impact of EECP on emergency room visits and hospitalizations. Clinical outcomes, number of ER visits and hospitalizations within the 6 months prior to EECP therapy were compared with those at 6-month follow-up. And there was a significant reduction in emergency room visits and hospitalizations. In fact, the results that was coming from Europe was also very similar with our results, and they showed an 82% reduction in their cohort, and they presented their results in Europe as well. FDA investigated almost everything we had done in heart failure, and they cleared the system for the treatment of heart failure as well in 2002. Now, of course, then we had some additional items to add to the benefits of EECP, and those were the reduction in hospitalizations, improvement in LV function, and low major adverse cardiovascular event rates at long-term follow-up. Today, more than 15,000 patients have been treated with EECP just for research purpose, and more than 200,000 patients have already been treated in the routine clinical practice. We came to realize after all these studies, and I have been doing research and doing clinical work on EECP for about 14 years now, and we came to realize that it really works. But back like 4 or 5 years ago, we really didn't know the mechanism of action. Within the last 4 or 5 years, several investigators, and I would like to mention here that these investigators were from different university hospitals, independent from each other, from different countries as well, started to do mechanism of action studies, and it indeed helped us to understand the mechanism of action. with the current knowledge we have, we believe that there are three major mechanisms of actions, and one of them is through the collateral development. What exactly we are doing with the EECP? It's a mechanical way to enhance the diastolic flow. When we enhance the diastolic flow, we basically increase the shear stress. When we increase the shear stress, we activate the release of growth factors. And when the augmentation of growth factor release activates angiogenesis. This is nicely said, but we need to see some proof. This is this study done in the lab settings, and this is a dog heart model. This is before contrapulsation, and this is after contrapulsation. However, how are we going to show this in human beings? One of the ways is looking at the growth factor levels. And this is what was presented in Canada. These investigators showed a significant increase after VEGF levels. And another group from Japan published their results in Circulation showing an increase in FGF, and VEGF levels. Now, this is the best study, I think, that talks about the collateral circulation in human beings. This is the study that was done by Switzerland's investigators, and they published their results recently. They basically assessed the effects of EECP on collateral circulation in human beings in a randomized placebo-controlled clinical trial in the cath lab settings. And this is the placebo group, and this is the actively treated group. There was a significant increase in collateral development after the treatment of EECP in the actively treated group. But when you look at the placebo group, and I think this is very important, when you apply low pressure, actually you may harm the collateral status of the patients. So this was the first study in human beings in the invasive cath lab setting showed the collateral development. The second mechanism of action comes from the vascular reactivity. Like athletic training, the vascular effects of EECP might be mediated through neurohormones. In fact, there are several studies looking at the effects of EECP on nitric oxide levels. This is a nice study published in European Heart Journal showing a significant increase on NO levels even if 1 month after stopping EECP treatment. This is another study I would like to share with you. This is also done by French investigators. It is a placebo-controlled clinical study that was looking at the effects of EECP on plasma cyclic GMP levels. As you know, plasma cyclic GMP regulates the arterial function. And what they did, they used two group sets of patients. One of them with the high-risk group did not have any coronary artery disease, but had all type of risk factors. And then the other group had the coronary artery disease. And in this placebo randomized study, in both groups, they were able to show that there was a significant increase in plasma cyclic GMP levels after EECP application, which kind of shows the arterial function improvement. And the third mechanism of action is through endothelial function, which I will not mention anything about it because Greg will be giving a nice talk on the effects of EECP on endothelial function. I think this slide basically summarizes the effects of EECP and its mechanism of action. This is your coronary artery tree. Say that you have an occlusion right here. What exactly we do with bypass, which is a great treatment, but we bypass this occlusion. What do we do with stenting, which is another great treatment for a certain group of patients, but we basically open up this occlusion. While we are fighting with this lesion, this is a progressive disease. You will have different occlusions in different places. Have I ever told you that EECP can do that? Absolutely not. EECP uses this occlusion and pressure gradient to open up the sleeping arteries, arteriogenesis, and also to create the angiogenesis. So it basically works on this part of the heart, increasing collateral circulation, balancing and improving the neurohormones, and increasing the endothelial function. This is how it complements the currently available treatment strategies. One of the major important issues in the routine clinical practice, not in the research, is that how are we going to follow up these patients in the routine clinical practice? Should we do CAT, pre and post evaluation? That would be very costly and invasive. So I think that's not the way to go in the routine clinical practice. Should we do pre and post echo evaluation, myocardial perfusion imaging? If you can, that would be great. But again, it will be time consuming and costly in the routine clinical practice. I'm not talking about the research. Then we need to find easy on the spot tools to use to evaluate the effects and to share it with our patients. One of them could be, of course, the symptom, because the symptom is the thing that brings the patient to us. So we can follow them through symptoms, assessment of functional capacity, and quality of life. These are very easy things to do for the follow-up. We can apply 6-minute test, which is also another easy test to do. And then we can use endothelial function measurements. As I mentioned here, the third mechanism of action of EECP is coming through endothelial function improvement. Therefore, measuring that would be a nice tool to use in the clinical follow-up. And of course, there are several different types of endothelial function measurements, but we need to choose the things that is non-invasive, accurate, reliable, easy to use, inexpensive, and done maybe in 10 to 15 minutes so that we can communicate that information easily with our patients. I thank you for your attention.